Wow. I can't add anything to what's been said, but there'll be some symmetry here because I think we've had two really nice descriptions of potential technical solutions to some of the problems. And are you familiar with the work of Heifetz and Leadership on the Line, in which sort of draws a distinction between what we might call technical challenges and technical solutions, which is where you've got some pretty good ideas of things you can put into place that are frequently procedural or mechanical or related to something like that. And you can have a pretty good idea you're going to fix some things with that. For those of us who are simple-minded, I really like these things. I just have to execute, and it's a great way, particularly when people need and they're beginning a career. They need to know what to do, and you can solve a lot of problems this way. And we have to solve a lot of problems. We need actual technical solutions to the things that are coming at us. The other type of problem is more of an adaptive one. In those situations, the answers are frequently not known and need to be discovered. The way you implement those is far less linear, far less hierarchical, and actually you do need high-functioning, typically teams and collaborations where you can allow a certain amount of free thought. I think some of the, and you kind of acknowledge the messiness of this stuff. And I think as I just think about the team of the future, healthcare team, first of all, it will not look like the four people at this table in several respects. It won't be 50 male, 50 female. I'm sure it'll be about, actually yesterday, as part of my job as the senior advisor, I'm very senior advisor for patient experience at Park Nicola. I get to see all, and Health Partners, I get to see all of the new clinicians their first week and again a few months later, and we work on some of the communications things that we do there. The group I met with yesterday, 15 new clinicians. Every single one was female. There was one MD, and everyone else was either a nurse practitioner or a PA. And I think that's a lot closer to what the future of our healthcare teams are going to look like. And in healthcare, you were kind of railing against the fact that we always get compared to the airline industry, and if it's not the airline industry, it's Starbucks, and if it's not Starbucks, it's Target. And it's interesting how nobody ever compares us and say, why can't you be more like education? And then yet, really? No one says, can't you be more like education? And yet education is really our natural parallel. We are a lot more like education than we are like Starbucks. It is a much more complex situation where society has handed off a lot of problems that society doesn't really want to deal with it and says either in education you guys take care of it or in healthcare you take care of it. So when you're dealing with these very complex problems in the primary care, and sometimes we see those in specialty too, a lot of these are social. And they're families that can't take care of their own people. They're people who really have no place to go and live. As we think about teams, a couple of things to think about. Patients and families consider themselves part of the teams. And so these teams are not just about us. And our ability to successfully incorporate patients, and particularly in chronic disease, into these teams in a really contributing way is going to be extremely important. I think the other issue that I think you were bringing up really nicely with the value is the difference between a micro team and a macro team. We think a lot about micro teams. The nurse I work with, the PA that I work with, my colleagues, and we're cardiology, and we're on cardiology, but we work together pretty well as a micro team. But the reality is my patients expect us to be bridging across the departments. And actually, if you look, and I'll be very honest, I get to look at the entire HP family of care patient experience data. They do not give us very high marks when it comes to crossing different departments. We consistently see in our numerical data patients telling us, you don't know my medical history. And what they really mean is, you haven't convinced me that you've talked to anybody else that I get my care from. And so I think this business of thinking really broadly in terms of who is really a part of these teams and how we collectively function together, I think that's something we really can do a lot better. And I think we can. But that's a challenge for us, and that will be effective teams of the future will be able to do that. And finally, and then I'll get off my little high horse, during my time as the senior medical director for the medical specialties, I saw a lot of really great teams. Our pediatric endocrinologists have really perfected a process of starting new diabetic kids on insulin, never admitting them to the hospital. Huge amount of phone care, huge amount of great work keeping them out, really hitting the triple aim. We have yet to get any payer to be interested in paying for this. This all just comes out of their hide. And in case you don't know, pediatrics endocrinologists may be specialists, but they're not the high pay. They're not like a cardiologist. They don't have money to throw away. We had great team-based care with nurse clinicians with heart failure. A lot of phone care there. That fell apart because of funding. And I think a really effective team-based care will need financial models, and right now those are few and far between. And so we can't, just as like you don't want to lead with finances on education, but I think as we're looking at these new models of care, these exciting new models, this really has to be done in certain extent with our payers so that we don't get too far out in front and have a great model that will not support itself.